Alright, welcome back to Midnight Med. This video is on Parkinson's disease. The classic presentation of Parkinson's disease includes Parkinsonism, which is defined by bradykinesia, that is, slowness of movement, with either a 4 to 6 Hz resting tremor, rigidity, or both. Patients with Parkinson's also often report subjective weakness, but when they are tested, they actually have normal power. The symptoms typically arise asymmetrically. And there are also classical non-motor manifestations that are observed. These include constipation, daytime urinary urgency, anosmia, that is, the inability to smell, REM sleep disorder, and depression or fatigue. The development of Parkinson's disease is related to the loss of dopaminergic neurons in the substantia nigra pars compacta. These neurons are responsible for providing dopamine to the basal ganglia, which is the key neurological network responsible for the planning and modulation of movement patterns. This explains the responsiveness of the symptoms to levodopa, a synthetic form of L-dopa, which is a precursor to dopamine that helps increase dopamine concentrations centrally. The cause for the neurodegeneration is not known, but it is believed to be related to the accumulation of alpha-synuclein, a key neuronal protein, in both the neuronal cell body and the neuronal processes, forming Lewy bodies and Lewy neurites. Further, it's also important to note that there are other neurons related to the basal ganglia that are affected in Parkinson's, so it's not just the dopaminergic ones. Some of the risk factors associated with Parkinson's disease are age, family history, and PARK genes. So that's PARK. These are the genes that confer some level of polygenic risk of Parkinson's disease. In addition, exposure to pesticides, herbicides, and the chemical MPTP is also associated with Parkinson's disease. Things that seem to decrease the risk of Parkinson's disease include cigarette smoking and caffeine intake. I should stress, though, that we do not endorse smoking, and any potential risk benefit in Parkinson's disease is likely to be minimal. The diagnosis of Parkinson's disease is a clinical diagnosis based on the criteria from the Movement Disorder Society. The criteria aim to rule out some of the key differentials for Parkinsonism, such as progressive supranuclear palsy, Lewy body dementia, and multiple system atrophy. The diagnosis of Parkinson's disease requires the presence of Parkinsonism, in addition to 2 supporting criteria and an absence of exclusion criteria, as well as no red flags. The supporting criteria are, firstly, a response to dopaminergic therapy, so that's levodopa, or on the flip side, the presence of dyskinesia, that is, involuntary movements like twitches and jerks, when taking levodopa. Also, a resting tremor on examination is a supporting criterion, and positive results from at least one ancillary test. So the 2 ancillary tests are testing for either olfactory loss or demonstrating cardiac sympathetic denervation on scintigraphy. And remember, only 2 of the supporting criteria are needed to support a diagnosis of Parkinson's disease. The key exclusion criteria are generally things that might suggest an alternative explanation to Parkinson's disease. These criteria include cerebellar anomalies, supranuclear vertical gaze palsy, particularly in down gaze, which is characteristic of progressive supranuclear palsy. Additionally, the presence of probable frontotemporal dementia or primary progressive aphasia. Further, where the Parkinsonian symptoms have been confined to the lower limb for more than 3 years. Another exclusion criterion would be the presence of cortical sensory loss. So, for example, the loss of stereognosis, which is the ability to identify solid objects by touch, and the loss of graphesthesia, which is the ability to identify writing on the skin purely from touch. Additional exclusion criteria include normal functional neuroimaging of the dopaminergic system, the absence of a response to levodopa therapy despite having at least moderate severity disease, or treatment with a dopamine receptor blocker or dopamine depleting agent, because these could also produce Parkinsonism. Also, having another documented illness that could possibly explain the Parkinsonian presentation is grounds for exclusion also. Some of the key red flags that would exclude a diagnosis of Parkinson's disease include a rapid progression of gait impairment, so potentially requiring a wheelchair within 5 years. Alternatively, complete absence of progression, where the stability is unrelated to the treatment. the presence of bulbar dysfunction within the first 5 years. So, bulbar dysfunction includes dysphonia or poor voice quality, dysarthria or difficulty speaking, and dysphagia or difficulty eating. Another red flag would be any inspiratory or respiratory dysfunction, like stridor. Further red flags include things like severe autonomic failure in the first 5 years of disease. So, that's orthostatic hypotension, urinary retention, or incontinence, and also recurrent balance related falls early on in the course of disease. It's also a red flag if none of the non motor symptoms are present, or if there is no side predominance to the symptoms. Once a diagnosis of Parkinson's disease is confirmed, it is time to consider management strategies. Parkinson's disease is usually treated with a combination of levodopa, which I've mentioned earlier, and carbidopa, which is a decarboxylase inhibitor that prevents the conversion of levodopa to dopamine in the peripheries. This combination therefore ensures optimal dopamine levels within the central nervous system. However, it should be noted that this treatment is merely symptomatic, and the disease will eventually progress until it is not sensitive to treatment any longer. It is also important to employ a multidisciplinary approach to management. The gait and balance would benefit from physiotherapy, and non-motor symptoms such as anxiety and depression can be managed using medications like SSRIs. So that's it. Thank you for watching. Don't forget to like, subscribe, follow us on Instagram at midnightmed1200 for more, and we'll see you in the next video.